They have these age ranges, so you can look at like, I don't know, I'm just making something up. Like if you wanted to know, like in 2022, how many people between the ages of 13 and 24 were diagnosed with HIV in the United States? Like there's a column for that. But, in our world of HIV, we tend to look at an older adult is somebody who's 50 and older. Mm-hmm. Well, the data's not sliced that way.
Hey everyone, Raif Derrazi here, and today I'm in Minneapolis at the 2025 Minneapolis Statewide Conference on HIV, the inaugural conference.
Well, it's been like, I think 30 years of this kind in Minnesota.
Okay, so for many people, this is the first in their lifetime.
Probably.
And so today I'm here with Terri Wilder.
Hi.
Hi, how are you?
I'm good. I'm a little tired, I have to be honest.
Yeah, me too.
Ripping and rolling at this conference.
It's kind of like every conference is like that.
Exactly.
So you and I have met, I think a couple times now at least.
Yeah.
I think initially was it in Munich?
Oh, yeah. I think we did meet in Munich.
Yeah. I saw you speak, and then I reached out to you because I wanted to interview you, and we're finally doing it a year later.
Got it.
Okay, so I don't have a biography for you today. I usually will introduce my guest. So would you mind giving a brief biography?
Yeah, sure. So I'm Terri Wilder. I currently work at SAGE, which is the nation's oldest and largest organization serving LGBTQ plus older people. And that includes older people with HIV. And we were founded in 1978, so we've been around for a really long time. And my role at SAGE is I work on all of our HIV and aging policy. So I'm part of our policy team. And I'm a social worker by training. And I've been doing this for a minute. I started in 1989. And so,
wow.
Yeah. So, but I look great, right?
You definitely look great.
I know I tricked you into saying that, but yeah. So I've been a social worker and was there at the very beginning, if you will. So I certainly took care of folks in inpatient hospital units. I was a case manager at an HIV clinic. I worked in nursing homes, hospice. I did a pediatric HIV work for a while and ran a HIV education empowerment weekend for folks living with HIV who are newly diagnosed. Had a little stint in city government at a Bureau of HIV. Worked at a big hospital, ran an education department focusing on training healthcare providers on HIV. And then I kind of feel like I have my dream job because I'm a bit of an activist. Mm-hmm. And they actually now pay me full time to be an activist.
Amazing.
So I'm excited about that.
Mm-hmm.
So the dream job has finally happened at this age.
And did you have a hand in this conference and putting it together?
I did, yeah.
I noticed you were, from the opening plenary and beyond, you've been very involved.
Yeah, so I was invited to be part of the planning committee. So I knew folks at the University of Minnesota, and they invited me to be part of it. I do have a background in education and clinical education, and so I was invited, and they actually were very generous in taking my suggestions, which, some people are like, okay, thank you, and we'll move on. But they really did take a lot of my suggestions. I mean, I lived in New York City for 13 years, and I got access to a lot of, the pioneers, in HIV and LGBT health, and I felt very lucky to have access to that brain power and that activism power, and just wanted to make sure that we had folks like Greg Millett at our conference here. And so, because I work in HIV and aging, they let us invite Dr. Ellen Landay, who's a really well-known researcher in HIV and aging, Dr. Shabani, who's a neurologist, Dr. Mark Brennan-Ing, who's really known for being part of the ROA study, which is really famous. It's the research on older adults with HIV study that was done with the late Dr. Steve Karpiak at ACREA. So yeah, I mean, they were like, who would you want to have come if you could? And I was
Amazing.
Like, well, this is my list. Mm-hmm. And we got almost everybody.
Amazing.
Yeah. So.
Well, now that we're in a place where people are living with HIV much longer than they ever have before, now the focus is increasingly on how do you live with HIV, especially as you get older, comorbidities, chronic inflammation, things that we're finding out all the time. And so is this something that you actively at Sage as well work on and seek to, is it specifically policy related? How policy handles those things?
Yeah, I mean, that's a good question. You know, I can't do my policy work if I don't understand HIV. You know, like I have to have a basic understanding of HIV. I have to know our language. You know, I have to be able to communicate in a way to help folks. When I go to an elected official, they're not experts on HIV like we are. You know, people living with HIV are experts. I'm an expert because y'all taught me, you know. And so I have to know things about inflammation and why is it important for research to be happening at the NIH around aging and HIV because of what you just said. We know that people living with HIV at a younger age are more likely to have comorbidities. We know that HIV is an inflammatory disease.
If you acquire HIV at a younger age, you're more likely to have comorbidities. Is that what you're saying?
So what I'm saying is when a person has HIV compared to a person who doesn't have HIV, you're more likely to get comorbidities at a younger age. And I'm saying younger, like 40s, 50s, 60s, you know, that kind of thing. And so if I'm trying to advocate or convince the NIH or the federal government or, you know, the people who are in power in DC that we need money, you know, sent to the NIH that to be distributed to these amazing HIV and aging researchers, I have to be able to tell them why.
Yeah.
So I have to understand some background things, you know, about what it's like to live with HIV. So I listen a lot. To people who are living with HIV, to people who are aging with HIV, long-term survivors, lifetime survivors, people, you know, who are 50 and older, 60, 70, 80 years and older, because those stories help me figure out where are the gaps, what are policies that I need to be fighting for, and what are policies that I need to be fighting against.
And policy, funding, those are all very important right now.
Yeah.
More than they have been in recent history, it seems.
Yeah. I mean, you know, we're in a really, you know, we've talked about that a lot during this conference and a lot of different sessions. You know, I think we knew that it was going to be bad. I think folks are surprised how bad it is. And quite frankly, we weren't prepared. And so a lot of calls are happening every week, like the call that I'm on every Tuesday, the Save HIV funding campaign is a really great place to get information and really track what's going on because we're being hit. Like, you know, you open up your apps and you're like, oh my God, you know, it's just coming at us. Day. If you're on a million HIV listservs like I'm on, it's coming at me every day. So it's a lot to track and kind of sift through and figure out, you know, where does Sage take the lead on something? Where do we support? You know, like where is the place that we really need to step in? And because, you know, our whole focus is on older people living with HIV. And so those are the places that we really feel like we have to take the lead on or make sure that if there's a sign-on letter that comes through on an email listserv, I read them and check for accuracy. But I'm also looking, did they say anything in the sign-on letter about older people with HIV? And you can ask anybody in our community if they do not have a sentence about older people with HIV or aging with HIV, they get an email from me that says, well, I'm nice. No, I mean, I'm not ugly to people, but I just say, hi, thank you so much for sending the sign-on letter. I just want to let you know it makes it really hard for Sage to sign on to a letter if we are not recognizing how this issue impacts older people living with HIV or people aging with HIV. I found the perfect sentence in this letter, and I'll cut and paste it, and I'll say, do you think you could edit this sentence to say this? And about 9 times out of 10, I rarely have people email me back and say no. They'll say, oh, thank you so much for bringing that to my attention. The other day I had somebody say, Terri, I'm so sorry, you remind me of this every time. but they'll change it.
Yeah.
And that's my job.
Yeah,
that is
advocacy.
my job, to make sure that older people with HIV are recognized in these letters that are going to senators and congresspeople or people in power at other parts of the federal government, to make sure that they're not forgotten and that their needs are elevated. That's my job.
Yeah.
So,
what are some of your top concerns right now for those aging with HIV?
Medicaid. The Medicaid cuts is something that I'm really concerned about.
I think this is such a nebulous kind of idea, especially when I see it on social media. Like, you hear everything from, people are going to be dying on the streets and not have anything, to, oh, this isn't that big of a deal, it's overhyped. Like, it's hard to parse through all of that.
Yeah. I mean, there's a lot of conversations happening at the federal level, but where I live here in Minnesota, there was a lot of conversations at our Capitol, because Medicaid's state, but, there's federal dollars that help support different things. And, Medicaid is one of the single largest funders of HIV medical care. And remember, Medicaid doesn't just provide care like to go to the doctor, just to see your healthcare provider, your nurse practitioner. It also pays for like medical transportation. And so think about the folks that, I work with and that I fight for. As you get older, you may not be able to take the subway or the bus just because you're frail, or it's harder to, move around. And so you really are going to depend on one of those Medicaid reimbursed transportation systems. So if Medicaid went away, well, how are these folks going to get to their medical appointment? And then how are they going to, have that medical appointment paid for, their medications, et cetera, et cetera. Yeah. So, in Minnesota, I remember in the early 1990s, we had these adult foster care homes for people with HIV. And it was a kind of alternative to a nursing home. Because remember, from 1992 to 1996 in Minneapolis, Minnesota, I was a case manager literally up the street at the HIV clinic at Hennepin County Medical Center. And my clients were dying. I mean, it was before protease inhibitors. They were dying. And I just had to make sure that they could die with grace and dignity. And these were young people. So these were people in their 20s, 30s, 40s. And so we had a couple of nursing homes that would take care of people living with HIV. But I've never met a person in my life living with HIV or without HIV who wants to be in a nursing home. Yeah. People that's not where they want it in their life for very valid reasons. And so what happened was these folks in the community, they were community people. Some of them, there was one assisted adult foster care home that was created by Franciscan brothers. It's like a sect of this religious brotherhood. So they opened adult foster care home. There was a Agape home. There was Claire Housing. There was, I think, a couple of other ones. But that is where my clients wanted to go and die. And it was Medicaid reimbursed. So if my clients had Medicaid, that was the first step that I could, fill the application, really advocate for them to get an interview, because these were houses. So they were home-like settings. They usually had 3 or 4 bedrooms. So they were very hard to get into. And you knew why there was an opening. If there was an opening, it meant somebody had died. Yeah. And so this is, these are things that I'm like, as the community is aging with HIV, they're going to need alternative places if they don't have family or friends available to take care of them as they age, if they have some comorbidities that require some additional care. And so I'm wondering if we're going to need to start having a conversation about bringing back the adult foster care home model, and then it be Medicaid reimbursed. So all these things are in my head about oh my God, I want to make sure people can go to their doctors and blah. But I'm also thinking, I wonder if as a country and as a community, we're going to start talking about across the country adult foster care home model again as an alternative to nursing homes. When we look at data for LGBTQ plus older folks and older folks living with HIV, we do see some information that says that they're less likely to have adult children that can be available to take care of them as they age. or even family. Of course, there's family of choice, but they're going to be more likely to end up in an institutionalized setting, i.e. a nursing home, or an assisted living home or something like that. So that's why I've kind of been, as this Medicaid conversation's been happening across the country, I've started thinking, I wonder if we're going to have to bring back the adult foster care home model for people living with HIV, which they loved. All my clients loved it.
Yeah.
I mean, they got to live in these like Victorian homes, and there were staff there to really cater to their needs. It wasn't like this institutionalized setting where it's like everybody gets macaroni and cheese and Salisbury steak for lunch. You know, the person would come in the room, they'd be like, hey, it's breakfast time. Are you hungry? Do you want something? They'd be like, yeah, can you make me, I don't know, a scrambled egg and some toast and like one piece of bacon? They'd be like, I'll be right back. Great. So it was very kind of like, you know, homey, and they would take care of you. I remember one of the homes that a client that I got a client in, they actually had a hot tub. So, you know, if you were having pain or you needed some, you know, that stuff makes your muscles feel good. Like they could just go get in the hot tub. So they were really great, and they were home-like, and they really blended in with the community. Like if you drove down the street, you wouldn't know it was an adult foster care home. You would just think it was somebody's house.
Yeah. And isn't that what you want?
Of course. Yeah. I mean, I want to die in my bed with my cat.
Yeah.
You know?
Yeah.
So.
And does Medicaid funds Ryan White?
No. So Medicaid's a different system than Ryan White.
Okay.
Yeah. So Ryan White is, you know, it's a federal piece of legislation that was enacted in 1990. I always have to give the shout out here. I'm like, the queers are brilliant. They had Elizabeth Taylor show up on the day that it was going to be introduced because we want all the white heterosexual men who run our country to show up to see the sexy starlet who tells them this is the right thing to do, and then they vote yes. I mean, brilliant strategy, brilliant. Yeah. So it was introduced in 1990. It's the largest piece of legislation like this, you know, to fund HIV services. And, you know, it does fund services like, you know, a lot of HIV clinics get Ryan White funding. Case management is often funded by Ryan White dollars, but it's a completely different system. Yeah.
Okay. You mentioned in this past presentation, and then I've seen it before too, talking about getting rid of the upper age limit on things like testing. Yeah.
Yes. It's like the thorn in my side.
Yeah.
Yeah. So for decades now, the Centers for Disease Control and Prevention's HIV screening guidelines, which, you know, probably most people call the testing guidelines, it's guidelines that is something that healthcare providers look at to just give them guidance on HIV testing, how to do it, who you should offer the test to, that kind of stuff. And so for decades, it's said, you know, people 13 to 64. Well, you can imagine at SAGE, that specializes and supports and advocates for older people, we have a problem with that. You know, it's like, why is there this kind of age kind of limitation here? Because we know that, you know, you don't magically stop having sex at 65. You don't magically stop using drugs or whatever. And so, you know, we've advocated for years that the upper age limit be removed. And some people are like, it's a guidance, it's not a law. I know, but when you read something like that, it kind of gets ingrained in your brain. And,
exactly.
And as a clinician, you may be like, oh, 13 to 64, oh, they're 65. Like
unconscious bias.
Well, and there's something called ageism, you know, that's kind of layered in that. And so for years, we've been advocating for the removal of it. And I'm pretty sure the CDC hates me. No, I'm kidding. I mean, I've just been very vocal about it and, you know, kind of corner CDC officials. They're like, oh my God, here she comes. So I got to go to the bathroom. But so what happened that was pretty amazing was last year, they released their updated guidelines. Now, guidelines are not something like, can you guys just remove it? You know, there's a process. They have to do extensive literature review. They have to have, you know, scientific literature to back up the decisions that go, why they put what they did in these guidelines. So it's not something that like, oh, hey guys, Terri Wilder called. She wants us to remove the upper age limit. Sure, we like her. Let's do it. Yeah. It's a process. So they did their extensive literature review. Somebody has to write it, somebody has to review it 800 times. I mean, the government, everybody has to review it.
Bureaucracy. Yeah.
And so the updated guidelines were kind of released to the public. It was the draft. And there's this kind of like opening letter, if you will, from like Dr. John O'Merman saying, here's our updated draft. It's open for public comment. They're due by this day. You'll notice that there was one significant change, removing the upper age limit of the CDC's screening guidelines. And I was like, oh.
Amazing.
Yeah. And so then it was 30 days of public comment. And I was like, oh my God, calling everybody. Oh my God, national organizations, pharma, like everybody, like please write your letters of support, thank them, say this is the right decision, we support this, et cetera, et cetera. So we had a 30-day period to do that. And then, they have to really go through all those public comments. It's not like pro forma. They actually do have to read them. And I could see how many was coming through. Like I was anal. I would check it like every day. And sometimes twice a day. Because I just wanted to see like, oh my God, who's put one in? Oh, we've got 2 more today. Who was it? And I'd click open the PDF and I could read it.
Cool.
Because it's public.
That's cool.
And then January 20th happened. So they just kind of ran out of time to read everything, respond, kind of do whatever edits based on whatever in their discussion, based on the public comment, and kind of get it out the door.
And January 20th, you're referring to our new president.
We had a change at the White House, yes. And so I've just kind of been waiting. I've reached out to the CDC several times, and they have a lot going on right now. Yeah. People have been let go. People don't know what's going to happen to their job. They have no idea, like, what are the priorities right now? Like, there's definitely threats that have been made to just completely giving, the Division of HIV Prevention will no longer exist. And so, I think people have been, like, paddling water. And so the interesting thing, though, is that the PEP guidelines came out recently. So there were some updates to those.
Okay. That's post-exposure prophylaxis?
Correct. And so that gave me a little hope, like, oh, somebody is looking at guidelines and trying to get them, like, hit publish. So I've been trying to get in touch to folks at the CDC to be like, can you give me, like, is the window even open that we could squeeze it through? It's a very kind of awkward time. Like, I don't know what it's like to work at the federal government right now. I hear from people what it's like to work there. So I just don't even know at this point, is it realistic? Is it not realistic? If we try to publish, could somebody see it and then they block it? So I think there's, some things, but we got so close. And I really wanted to be like, victory, we did it. Yeah. It's taken years and years. I mean, we got real close. But we've had some other victories for the aging community.
Like what?
So we've had several long-term care Bill of Rights passed at the state level. And that's one thing that I want folks to also remember, that, like, the federal feels chaotic right now, and there's a lot of stuff coming at us. Don't forget where you live. Don't forget local. And what I mean by that is that, across the country, we've had many states pass LGBT and HIV long-term care Bill of Rights. And what that does is that it protects people with those identities from being discriminated against in long-term care facilities like nursing home, assisted living home, or even like a rehab facility. And I don't mean substance use disorder. I mean, like, I broke my hip, I have to go to rehab for 90 days or whatever.
Has that been a concern?
Absolutely. And I mean, we certainly saw discrimination at the beginning of the epidemic. I mean, I remember being in Atlanta and I can't find a nursing home that'll take this client that I've been working with in the hospital that needs to be discharged to a nursing home. I mean, this was the era where we couldn't find funeral homes to bury our friends. So there's a long history of discrimination, and people sometimes can think, oh, well, that happened in the 80s and the 90s. No. Pause Magazine ran an article a couple of years ago about a woman in Nebraska that was trying to find a nursing home for her father who was living with HIV, and 6 nursing homes turned him down. And she was like, I know what this is about. And she connected with the ACLU of Nebraska, and they sent some letters to the nursing homes with some probably really strong language, like, we're going to sue you. And eventually she found a nursing home for her father, and I think he died about a year later. But so this isn't something from the past. I mean, I know of a situation here locally where there was a assisted living home that had a resident that was living with HIV, and the staff refused to touch him. So this is very real. We do need protections for folks, and what it does is it protects them from being denied admission to the facility. It also has some provisions in it, like you have to be addressed by the pronouns that you want used and the name that you use, and that you're allowed to have people visit you that you want to have visit you. They can't like stop people from coming to visit you. There's also some provisions in there about, you can't just all of a sudden discharge them for, a not valid reason or that kind of thing. And there's also, probably the most important thing that we've really fought for is that there's a training component. The staff has to be trained on the LGBTQ plus community and about HIV. And so states like Oregon, New York has passed, New Jersey passed. I like to say California is an overachiever. They passed at the state, and then San Francisco passed. Montgomery County in Maryland passed. Connecticut passed, Massachusetts passed, and in Minnesota, we just introduced. So we introduced a couple of weeks ago. If anybody's read about our legislative session, it's been a little up and down, is probably the best way to say it. So we introduced.
How so?
Well, there was some fighting that happened. So at one point, it looked like there was going to be a 50-50 between the Republicans and Democrats. And there was like, well, we have to come up with a power sharing agreement. And then there was some fights over, this person really doesn't live in the district that they said. So actually there's 51% Republican, 49%. And it just drug out and drug out and drug out. And they wouldn't meet. The gavel couldn't, it was a mess.
Yeah.
So anyway, so kind of by the time we were able to get our Minnesota LGBT and HIV long-term care Bill of Rights introduced, we kind of had run out of time to have a hearing and those kind of things that kind of have to happen. So Senator Scott Dibble, who is an out gay man, he's actually my senator, is the lead on the Senate side, and then Representative Liz Rayer is our House rep. And they both have a lot of passion around aging and older people. And so they were a really good fit for this legislation. So it was introduced. We're probably going to do some kind of awareness kind of town halls about it in the fall. We may combine it with kind of a citizen advocacy trainings to prep people to start talking to their legislators, because we got to get those votes. And I will say that the thing that I'm really proud of about this piece of legislation is that it's going to be the first in the nation that not only has, the Minnesota LGBT and HIV long-term care Bill of Rights for the long-term care facilities, but we added protections for home and community-based services because older people get, home and community-based services. We thought California was going to beat us to the punch, if you will. And just add their home and community-based services to their already existing one. And they didn't do it before we did. So I was like, oh my God, Minnesota was first. So we're really proud that we can say that we were the first to have a long-term care Bill of Rights that also has protections for home and community-based services.
That's awesome. That's amazing. So I think it sounds like the big takeaway is things may feel like doom and gloom on the federal level, but there's still so much that states can do.
In your city, in your county. I mean, we're talking to folks at Georgia Equality, Jeff Graham, who actually happens to be my old boss, to look at introducing a long-term care bill of rights at either the city of Atlanta or Fulton County, because I'm from Georgia. It's probably would not pass at the state level. We're talking to people in Pennsylvania, and in kind of activism around the world, people say, think globally, act locally, and there's a reason for that. And so, think about, where do people living with HIV live? They live in their towns. They live in their cities. So, think about the days that you don't feel good with HIV, the days you do feel great with HIV, the days, you need services. It's in the town that you live in. So let's try to work with our state level, city level folks that can have power and help us get some things to improve the quality of life, which I think is kind of how you started this conversation was, at this point of people aging with HIV and getting older, we're really talking about quality of life. We know that if you have access to medical care in the United States of America and you can take your medicine every day, we can keep you alive. But it's about the quality of life as the years go by, right?
Yeah. And does Medicaid support other things like mental health services and things like that as well?
Yeah,
that
for sure.
would support quality of life.
Correct. Yes, correct. Exactly. So, Medicaid's a really important program for people with HIV. I mean, it provides a lot of stuff. I mean, I remember, when I, again, was the case manager up the street at the hospital, I could do these vouchers, like taxi vouchers, and I would write my client's Medicaid number on it. So I could call and set up taxi vouchers so that they could get to the doctor.
Oh, I see.
So they would call me and they'd be like, "Hey, Terri, again, it was the 90s. I don't feel good today."
For the Gen Z pre-Uber and Lyft.
Correct. Like a yellow taxi. Like if you've been to New York City, you've seen the yellow taxi.
Yeah.
But, I remember I would have clients that would call me and say, "I need a ride to see my doctor today." And I would be like, "It's no problem. I can set it up." And I had these taxi slips, and I would write their name on it and the address, and then I would, because I have access to their medical records, I could look up their Medicaid number, and I would just write hashtag and the number.
Fascinating.
And Medicaid would be billed for that taxi ride because it was medical transportation. Wow. And then I'd call the client, I'd say, "Okay, they're going to pick you up." Like, I knew what their address was and how probably long it would take the taxi to get to Hennepin Medical Center, and be like, "Okay, so I've set it up. The taxi is going to pick you up tomorrow at 2:30 for your 3 o'clock appointment. Just be watching out the window or sitting on your front stoop or whatever to watch the taxi pull up."
Yeah.
So, Medicaid has a lot of things that it does for people to make sure they get their needs met.
I've been hearing that HIV prevention is being deprioritized, to say the least. Yeah. Is that impacted through Medicaid as well?
So the dollars that for CDC are federal dollars that come from, our government decisions around funding. And so the Medicaid dollars don't impact like the CDC's funding that pays for staff and the programs that they work on. But, I'm very concerned about the Division of HIV Prevention going away at the CDC. Like, who's going to do that work? I mean, how are we going to know how many people are living with HIV in the United States if we don't have epidemiologists that work within the Division of HIV Prevention so that we know what does our epidemic look like? I mean, the reason why we found out that we had an outbreak in Indiana under Mike Pence as governor is because we have epidemiologists that were going, "Whoa, wait, something's happening." Yeah. Because every time, there's a positive HIV test, that gets reported to the CDC and they can start seeing a trend. And that's how we knew, that's how they figured out, it was folks who use IV drugs, and then you can do an intervention and you can do harm reduction, you can do syringe exchanges. I mean, in Minnesota, we had an outbreak too. So we had these homeless encampments that they figured out that kind of was where kind of the outbreak kind of happened here in the Twin Cities. For those of you that don't know what the Twin Cities is, it's Minneapolis, St. Paul, because we're like right next to each other. But also we had an outbreak in Duluth, Minnesota. And so how were we able to figure that out? Because the CDC, the Minnesota Department of Health, realized as data was coming in, whoa, something's happening, something's shifting. And then when you get that data, you can respond to the community's needs. You can make sure people get connected to care. You can make sure that, if folks need clean needles or they need hepatitis screening tests or they need, you can just help people. So there's some really bad consequences to the Division of HIV Prevention going away from like tracking our epidemic, but also, these are people that have like PrEP campaigns, that you could go to the CDC website, you could download JPEGs to put out on your social media that talk about PrEP in certain communities. People go to the federal government websites to get information on PrEP, acute HIV, where to go get tested for HIV in your community. So if we're going to dismantle that and the funding's going to go away and there's no human beings doing that labor, what's going to happen to our HIV epidemic?
Yeah. I heard that their intention is to roll it into some other...
Right, but what is that going to look like?
And then you're losing the data tracking component that the CDC specializes in.
Yeah,
Right?
I mean, we don't know what, like, oh, we're going to move these people over here and that kind of stuff. But like, how is that disruption gonna impact the way that we are used to the CDC supporting HIV prevention efforts? I mean, Greg Millett was here at this conference, who works for amfAR, and amfAR did analysis about what would happen if like 100% of the funding went away for the CDC's Division of HIV Prevention. What would that look like in terms of new HIV cases, AIDS-related deaths, and what is the economic cost to that? Because it's expensive to have HIV. So they looked at it 100% and they looked at it at 50%. And so I would encourage people to go to the amfAR website and read it's like a 2-pager document where they did analysis. I mean, it'll kick you in the gut.
Yeah. I'll try to remember to put a link in the description box below for that. Yeah. And then if I can find the graph that they made.
Yeah. It's a beautiful analysis. I mean, when it came out, I was like, thank you, amfAR.
Yeah.
Like, you always come through with your analysis.
Yeah. What was that in your presentation yesterday? You had a slide that you said, this is the slide that keeps me up at night.
Yes. So, the kind of one of the other things that I'm kind of thorn in the side of the CDC is if you look at CDC's epi data, they have these age ranges, so you can look at, like, I don't know, I'm just making something up. Like, if you wanted to know, like, in 2022, how many people between the ages of 13 and 24 were diagnosed with HIV in the United States? Like, there's a column for that. But, in our world of HIV, we tend to look at an older adult is somebody who's 50 and older. Well, the data's not sliced that way when you look at kind of HIV epi data. It's like the age catchment area is like, I think it's like 44 to 54. And I was like, well, that's not helpful to me, like when I'm trying to make my case about like trends. And so I kept saying to them, why can't you do 50 to like 55 for me and like 56 to whatever. And we went back and forth and they finally did change it.
Really?
And then one of the reports came out and it was still wrong again. And I actually was in a meeting with this woman from the CDC and I went up to her and I was like, why won't you guys help me out? And she goes, Terri, we did it. We did what you said. And I said, no, you didn't. This just came out today. And she goes, that was an error. That was not supposed to happen. We did change it. So, I just need this data to be good because data tells us stories and it gives us information. I'm going to get to your question. So the slide that I showed folks was from 2022. And the slide had those kind of age ranges. And what I put a box around, and I have to give credit. This was Dr. Jeffrey Kwong's slide. Thank you, Dr. Kwong.
And I'll put that up too.
Yeah. And so the one that I wanted the audience to look at, that a box kind of flew up just to make your eyes go to it, was the one that was like 55 to 64 and 65 to like over 70 or something. Yeah. And it showed you the number of people in those age ranges that were diagnosed with HIV in the year 2022 and the percentage. And so I wanted people to look at that. And then the next click was that of those older people who were diagnosed with HIV, the next box that flies up shows that 34.1% of the people that were diagnosed concurrently with AIDS. And so what we've found is that the older you are when you're diagnosed with HIV, the more likely you are to be concurrently diagnosed with AIDS. So what that says to me is that when an older person comes in for their primary care, like their annual, like listen to my lung, hit my knee, ask me how I'm doing kind of thing. Yeah. We're not asking about sexual health. We're not asking them about HIV, STIs, their sex life. How do you have pleasure? Anything like that. And so what's happening is that folks are not being offered an HIV test. They're not having these conversations. So the clinician's not asking it. The person who's older, because we certainly don't do good HIV education with older people, so they don't know to ask for it. And then by the time they find out they do have HIV, it's usually they're in the ER or they're been admitted to the hospital and they're told, oh, you have HIV and you're concurrently diagnosed with AIDS. So that's a failure to me.
Oh, yeah.
That's a failure. And that's ageism.
We're talking more than 1 in 3 people.
Yeah. So that's ageism.
Yes.
Combined with probably racism, sexism, homophobia, transphobia, and just also a sex negative perspective of older people having HIV. I mean, how many times have you heard someone say, oh my God, it was so gross. I walked in, my parents were having sex. Or a TV show that has that narrative. Yeah. Like, that's ageism. Yeah. Right? Yeah. Like, I want my parents to have sex. Yeah. Like, I want to have sex when I'm 80. Like, so it's like, these things impact people's ability to have sexual health services. Yeah. And this is the consequence.
Which directly supports your argument about the upper age limit of HIV testing.
Correct. Yeah, correct. And I mean, I have to say, this wasn't like Terri's fight. I mean, of course, there's other people that have been thinking about this and doing this work for a very, very long time. But, it was just something that when I saw that 34.1% kind of thing fly up on Dr. Jeffrey Kwong's slide, I was like, this is bullshit. That's like, I mean, we're literally killing people because of ageism.
And when you're that old and if you're diagnosed with AIDS, then how much more likely are you to not recover versus a younger person?
Yeah. I mean, exactly. I mean, as we get older, there's gerontologists who can talk about like the geroscience of like what happens to our bodies as we get older. Yeah. Is our immune system as strong or not? Yeah. So like, I don't have HIV, but as I get older, it's harder to fight off a cold. Like, I get more fatigue, those kind of things. And so there's this kind of natural thing that may happen. And then you've got HIV, which we know is inflammatory. And so, we know that people do better when you find out that you have HIV as soon as you acquired it, and we can get you the medical care to slam down the virus and help you lead that healthiest life you can and prevent opportunistic infections and comorbidities and doing some things around diet and exercise and all the things, our mama always told us we're supposed to do. Like, don't drink, don't eat, McDonald's every day, those kind of things. Yeah. But if you don't know, you don't know. Yeah. So.
Well, I know you have a presentation to get to. Yeah. I'm so glad we could squeeze this in. Yeah. And I would be really excited to continue this conversation periodically as new things happen as they're going to. And if something comes across your desk and you're like, I want to update Raif's audience, then let's hop on and do that.
Happy to. And just a reminder that National HIV and Aging Awareness Day is September 18th. And I think more and more people are getting interested in aging and what does that mean? And and what should we be looking for to help people have a quality of life that they deserve? And this year, the United States Conference on HIV and AIDS, the theme is HIV and aging. So it's good to know that the HIV community is not like kind of looking the other way about folks aging and getting older. That we're actually like, what, we need to think about this because our community is getting older. And when we look at the United States, 54% of all people living with HIV are 50 and older. And quite frankly, at the end of the day, when people are like, why are you so passionate about aging and HIV? Like, I know it's your job, but like you kind of go a little overboard. You know what? These are my friends. These are my friends. Like my friends were diagnosed with HIV in the 80s and 90s. I'm just fighting for my friends. So
I love that.
Yeah.
Well, folks, please post your comments down below. And if you have questions for Terri, I'm happy to follow up as well. Please like this video, subscribe, hit that bell so you get a notification every time a new video comes out, and please share this with anyone who might find value in this type of content. Those are the best ways that you can help support me and my channel. All right, thanks, Terri.
Thank you.
Until next time, cheers.